Good morning, everyone, and welcome to the Friday morning TIRO MDS programming. I hope everybody is well, and for those of you who are in this part of the universe, hopefully you are enjoying summer. For those of you who are not, hopefully it's not too cold where you are here. We have a really fascinating program and an outstanding panel this morning for a topic that has brought about quite a bit of controversy. And as always, I welcome all of our listeners to send in their questions this morning. We will have a fair amount of time before the 9 o'clock hour here in New York to entertain questions. And so I will do my best to make sure that I address those. I would also like to just highlight that the TIRO podcast series continues. Voices of Wisdom. We have another podcast due to be released next Tuesday. These have truly been outstanding, and Dana Hartle has done just an outstanding job. Our lineup will continue well into 2016. 2026. And so stay tuned, but I really encourage our listeners to listen to those programs. So our presenter this morning is Dr. Daniel Scholfield, who is currently doing his fellowship in head and neck surgical oncology at Memorial Sloan Kettering Cancer Center. Daniel completed his residency training in otolaryngology head and neck surgery at the Royal Marsden Hospital in London, and completed a research fellowship here in the United States in 2023-2024 with a focus on thyroid cancer genomics. Dr. Eyal Robenshtok is a frequent panelist on TIRO. He is an endocrinologist, thyroid cancer specialist at the Rabin Medical Center. He directs the thyroid cancer service at the Davidoff Cancer Center, and he's widely recognized for his work in risk stratifying the management of thyroid cancer. In addition to his leadership roles in many international endocrine societies, he plays a very active role and a very important role as a member of the TIRO Medical Advisory Board. Zubair Baloch is our third panelist this morning. He's a professor of pathology and laboratory medicine at the University of Pennsylvania. Dr. Baloch is widely recognized for his expertise in endocrine and head and neck pathology. His academic career has been extremely accomplished with over 200 peer-reviewed publications. He was co-author on the Bethesda FNA classification scheme and is co-chief editor of Diagnostic Cytopathology. In addition to co-authoring 3 books, he was co-editor of the Milan System for Reporting Salivary Gland Cytopathology, and he too is a valued member of the TIRO Medical Advisory Board. I'll just comment that all 3 of our panelists, except for myself, have some lineage that goes back to Memorial Sloan Kettering. And so of note is that Dr. Baloch and Dr. Robenshtok both did, either they did time or they did fellowship training, depending on how you look at it, at Memorial, and since have gone on to have brilliant academic careers, and if I dare say, have surpassed their mentors in many respects. You're not allowed to comment on that at all. So with that, I welcome everybody, and let me go ahead and turn over the program to Dr. Scholfield, and thank everybody for joining us, and thank our panelists here for their time.
Good morning, everyone. Thank you, Dr. Erkin, for the very kind introduction, and thanks for all the viewers logging in to join us this morning. Thank you to the TIRO MDS team. It's a real honor to present with such an esteemed panel. As Dr. Erkin mentioned, my name's Dan Scholfield. I'm one of the head and neck oncology surgery fellows at Memorial Sloan Kettering, and I will be presenting our paper, which was really a huge multidisciplinary team effort between the endocrinologists, pathologists, and the surgical team at Memorial. So the title of our paper is High-Grade Follicular Cell-Derived Non-Anaplastic Thyroid Carcinoma, correlating extent of invasion and mutation profile with oncologic outcome. Okay, so in 2022, the World Health Organization classification of endocrine tumors combined poorly differentiated thyroid cancer and high-grade differentiated thyroid cancer into one category, namely high-grade follicular cell-derived non-anaplastic thyroid cancer. And this is described as, in summary, an invasive and infiltrative non-anaplastic thyroid carcinoma with high-grade features. Sorry, I'm just going to change my view. Okay, great. So the terminology between these three definitions can be confusing. This table summarizes high-grade follicular cell-derived thyroid cancer by combining the historical terms of poorly differentiated and high-grade differentiated thyroid carcinoma. PDTC, as many of us know, is defined by the Turin criteria, which includes presence of solid trabecular or insular pattern of growth, an absence of conventional nuclear features of papillary carcinoma, and the presence of at least one of the following: raised mitotic count, tumor necrosis, or convoluted nuclei. High-grade differentiated thyroid cancer is defined as having cytoarchitectural features of well-differentiated thyroid cancer, but the difference is that these tumors had high mitotic count and/or tumor necrosis. And finally, another interesting but rare category is for lesions that exhibit high-grade features that do not meet the criteria for high-grade follicular cell thyroid cancer due to a non-invasive nature. And these are defined as encapsulated non-invasive neoplasms of follicular cells with high-grade features. Poorly differentiated thyroid cancer has an intermediate prognosis between well-differentiated and anaplastic thyroid cancer. Here you can see the 5-year overall survival. This is taken from SEER data, so well-differentiated thyroid cancer has very good prognosis, usually over 99% 5-year overall survival, compared dramatically to anaplastic thyroid cancer that currently has a 5-year overall survival of 10%, although we hope this might change with the new BRAF and MEK inhibition drugs. And data from Memorial Sloan Kettering previously showed that poorly differentiated thyroid cancer had 5-year overall survival of 62%. Along with the spectrum of survival and outcomes, there's also a spectrum of histopathological features across these three categories, with a more aggressive histopathology in anaplastic and poorly differentiated thyroid cancer. Previous research also shows a stepwise increase in the frequency of certain mutations, including TERT, P53, histomethyltransferases, and SWI, SNF chromatin remodeling complexes. These increase in frequency from well-differentiated to poorly differentiated to anaplastic thyroid cancer. There's very limited data on encapsulated non-invasive thyroid neoplasms with high-grade features. And there's currently a debate amongst pathologists as to whether these should truly be classified as carcinomas or as neoplasms. A small series published in 2010 from Memorial Sloan Kettering showed 8 of these patients who did very well in terms of their follow-up and did not have recurrence after at least 12 years. So in our current paper, what we wanted to do is define high-grade follicular cell thyroid cancer subgroups by their extent of invasion or extent of infiltration to compare tumor characteristics, mutation profile, and survival outcomes between these subgroups to hopefully give us an idea on potential treatment targets and to inform prognostication. So after institutional review board approval, we undertook a retrospective cohort study and identified 252 high-grade follicular cell thyroid cancer patients. They all had surgery at Memorial Sloan Kettering between 1986 and 2020. Tissue blocks from primary tumours were available for all of these patients. H&E tumour sections and immunostains were reviewed by our two expert head and neck pathologists, Dr. Hussain and Dr. Zhu. And then we proceeded to subclassify high-grade follicular cell tumours and its related entity, encapsulated non-invasive neoplasm with high-grade features. And here you can see a schematic representing these categories. So category A is the encapsulated non-invasive tumours with high-grade features. You can see the capsule is shown in green, it's complete there. The second category is encapsulated with capsular invasion only. We also termed this minimally invasive. And you can see in this schematic that there's a tumour bud penetrating the capsule. The next two categories are encapsulated angioinvasive tumours. The first one having focal vascular invasion, so less than 4 foci. And these areas of vascular invasion in this category are either vessels within the capsule or external to the capsule. The fourth category has extensive vascular invasion, so at least 4 foci of vascular invasion. And finally, how we traditionally would think of a poorly differentiated thyroid cancer is a tumor which is infiltrative. It's lacking a complete capsule, permeating the surrounding tissue in an irregular manner. And next, I'm going to show you some photomicrographs. So thank you to one of the co-senior authors, Dr. Hussain, for these. Firstly, you can see an encapsulated non-invasive thyroid carcinoma with high-grade features. So the arrow shows a complete capsule, which is not invaded. And then in the second photomicrograph, an area of necrosis. The second category, minimally invasive with capsular invasion only, has a mushrooming focus of capsular invasion in the photomicrograph labeled as C and shown with the yellow arrow, and also has mitoses, also shown with the yellow arrow in D. This slide shows encapsulated angioinvasive with focal vascular invasion. So here you can see a blood vessel invaded in an intracapsular vessel, and again an area of tumor necrosis in the second photomicrograph. Similar images here of encapsulated angioinvasive subgroup with extensive vascular invasion. So these must have at least 4 foci of vascular invasion. 2 separate foci shown in G and H here. And again, mitoses shown in the third photomicrograph. Finally, infiltrative high-grade follicular cell thyroid carcinoma. You can see tumor nests in J infiltrating non-neoplastic parenchyma with mitosis again in K. So after identifying our subgroups, we took DNA from tumor and matched normal tissue specimens, and this was available in just under half of our patients, so 117 patients. And then we sequenced the DNA using the MSK Impact platform, which is a next generation sequencing assay. It encompasses 505 cancer-related genes. We used CBio portal to analyze the mutation profiles of the different subgroups. And then we looked at oncologic outcomes. So we compared patient and tumor characteristics between the different subgroups. And I'll show you the data on all of this. We undertook survival analysis using Kaplan-Meier and log rank, looking at overall survival, disease-specific survival, and recurrence-free survival probability. Finally, the mutational landscape, which we analyzed with next generation sequencing. We compared between the subgroups to look for any differences in mutations. So here you can see the breakdown of 236 patients into the different subgroups. Half of the patients were categorized as infiltrative. The second most common subgroup was the encapsulated angioinvasive with extensive vascular invasion. This was followed by the encapsulated non-invasive neoplasm with high-grade features. And then with about 10% of the patients, encapsulated angioinvasive with focal vascular invasion. And finally, the minimally invasive subgroup, which was 5.5% of our patient cohort. Okay, so this is our first results table, which is a subgroup comparison of the clinical and pathological characteristics of the different subgroups. So in the first line, you can see that there wasn't a significant difference in age, although there did appear to be a tendency towards older patients presenting in the infiltrative group and younger patients having non-invasive or minimally invasive disease. There's also a tendency to male sex in the infiltrative and more aggressive subgroups. And as would be expected, looking at T stage, the infiltrative patients had a significantly higher T stage at presentation, 71%, presenting with T3 or T4 disease. This is starkly contrasting to patients with encapsulated non-invasive neoplasms, minimally invasive neoplasms who had over 80% presenting with T1 or T2 disease. This pattern of increased aggressive presentation continued. So the majority of infiltrative patients had regional disease with neck node metastases in the central or lateral neck, and no patients with encapsulated non-invasive disease or minimally invasive disease had regional lymph nodes on presentation. Excuse me. Again, no patients with encapsulated non-invasive disease or minimally invasive disease presented with distant metastases, and there was a similar proportion of patients amongst the angioinvasive subgroups and the infiltrative subgroups. About a quarter of the patients presented with distant metastases. As we would expect from a histological level, margins after surgery for infiltrative disease were positive in 50% of patients. And due to encapsulation, there were no positive margins in the minimally invasive and encapsulated non-invasive patients. Finally, around half of the patients with infiltrative disease and regional lymph nodes metastases had extranodal extension. This table summarizes the treatment characteristics of each subgroup. So the vast majority of patients with angioinvasive or infiltrative disease had total thyroidectomy, whereas thyroid lobectomies were more common in the encapsulated non-invasive subgroup. So 61% of patients in this subgroup had thyroid lobectomies. Neck dissection really reflects the end stage, which we've previously discussed. So half of the infiltrative patients had neck dissections, and for adjuvant radiotherapy, 15% of the infiltrative patients underwent this. And as expected, no patients in the encapsulated non-invasive or minimally invasive subgroups had required adjuvant radiotherapy. And finally, radioactive iodine was given to the majority of patients in all subgroups, apart from encapsulated non-invasive tumors. So our first Kaplan-Meier here shows disease-specific survival. These patients had a median follow-up of 62 months. And at the top in blue and yellow, you can see the flat lines of encapsulated non-invasive and minimally invasive tumors who had 100% 5-year disease-specific survival, with no disease-specific deaths in these subgroups. Comparatively, in the purple line is the infiltrative subgroup, who had a 5-year disease-specific survival of 67%, and then also doing relatively well in terms of disease-specific survival of the angioinvasive subgroups, with a 5-year disease-specific survival of 90 and 88%. This was a significant difference statistically between the subgroups. In terms of recurrence-free survival probability, the Kaplan-Meier follows a similar pattern, with the minimally invasive tumors we're not seeing any recurrences in that subgroup. But of note, that there are 2 patients circled here in red on the blue line, so the encapsulated non-invasive neoplasms, who had distant metastases, and these occurred quite late, and both patients were follicular variant PTCs, and both patients had NRAS mutations. In terms of the treatment of these 2 patients, they had completion of thyroidectomies, radioactive iodine treatments, and radiotherapy to their bone metastases, and both are currently alive. The next interesting thing on this Kaplan-Meier is there is actually a significant difference between the angioinvasive patients with focal vascular invasion and extensive vascular invasion. So focal vascular invasion seen on the green line, and extensive vascular invasion seen on the red line, with a 5-year recurrence-free survival of 94% and 76% respectively. So this just shows the importance of subcategorizing between extensive, i.e. 4 or more foci of vascular invasion, and focal vascular invasion, which is less than 4. The infiltrative subgroup, over half of the patients had recurrence over a 5-year period, so a 45% 5-year recurrence-free survival. This next set of Kaplan-Meiers shows the recurrences broken down into local, regional, and distant recurrence. And really what this shows is that the majority of recurrences were regional or distant. Sorry, this is quite small on your screens, but here you can see our oncoprints divided into the subgroups. So each column represents 1 patient, and you've got the mutations on the y-axis, and the different subgroups there. So the infiltrative subgroup first, followed by the angioinvasive with extensive vascular invasion, the encapsulated angioinvasive with focal vascular invasion, the minimally invasive patients. It's of course worth noting, in this rare subgroup, we only had DNA data available for 2 of the patients. And then finally, the encapsulated non-invasive subgroup. So overall, the most common mutations were TERT, which is the first row there in light blue, BRAF, NRAS, then IFAX, and then TP53. So we then compared key mutations between the different subgroups to look for any trends or significant differences. And this is a table summarizing our findings. And there was, interestingly, a significant difference. In TERT mutations, all of the subgroups, apart from encapsulated non-invasive patients, had about 40 to 50% of patients had a TERT mutation. BRAF mutations was the second column, almost exclusively seen in infiltrative high-grade follicular cell thyroid cancer, and a very low incidence in the other subgroups. So in terms of the 5th column there, synchronous TERT and BRAF mutations were seen in about 25% of the infiltrative tumors. Only 1 patient in the encapsulated non-invasive subgroup had a synchronous TERT and BRAF mutation. NRAS mutations were really driving mutations in the angioinvasive subgroups, with 75%, although only that only been 3 out of 4 patients, but 75% of the focal vascular invasion subgroup, and 50% of the extensive vascular invasion subgroup. Chromatin remodeling and epigenetic regulators were seen across all subgroups, and fusions were only seen in the infiltrative subgroup and the extensive vascular invasion subgroup, with the most common being rep fusions. So a few key discussion points. How is this data going to potentially affect management of these patients? In terms of the encapsulated non-invasive and the minimally invasive subgroup, over half of these patients in our retrospective cohort study were treated with a lobectomy alone. All of these patients tended to do very well, suggesting that often this is enough in terms of their treatment with close follow-up. However, the encapsulated non-invasive tumours, although appearing to be very indolent in terms of their presentation and how they appear histopathologically, do have a risk of distant metastases. So as mentioned previously, 2 of our patients in this subgroup developed bone metastases. Interestingly, they were both patients with NRAS mutations. So what we think is that for patients with encapsulated non-invasive tumours, but who have NRAS mutations, a total thyroidectomy and adjuvant radioactive iodine may be of benefit for these patients. The fact that 2 of the patients in this subgroup developed distant metastases supports the thinking that this subgroup is a carcinoma rather than a neoplasm. When we looked at radioactive iodine treatment, radioactive iodine uptake was actually seen in 81% of distant metastases, which is rather surprising, seeing as that the infiltrative subgroup were BRAF-like tumors, which historically or currently we would expect not to uptake radioactive iodine. Of course, the radioactive iodine uptake in the angioinvasive RAS-like tumors was significant as expected. We need further data really to see if this radioactive iodine uptake, particularly in the BRAF-like tumors, has any therapeutic effect on the lesions. And also beyond this, if there is destruction of RAI-avid lesions, does this significantly impact disease-specific survival? Because these patients often have multiple metastatic lesions and great heterogeneity histopathologically in these lesions. To conclude, what our data shows is that there is a spectrum of subgroups in high-grade follicular cell derived non-anaplastic thyroid carcinoma. This is from the rather indolent encapsulated non-invasive and minimally invasive disease to the angioinvasive disease, and finally the infiltrative disease. And each group has their own distinct histopathologic features, a distinct genomic profile, and different clinical behavior. The encapsulated non-invasive and minimally invasive tumors present with a low TNM stage. They're indolent in terms of their histopathologic features, and they do have an excellent disease-specific survival and low recurrence possibility. Although, as mentioned, we should note the fact that the encapsulated non-invasive tumors can later down the line develop bone metastases if they have RAS mutations. The angioinvasive tumors, key points are that the extensive vascular invasion tumors with 4 or more foci of vascular invasion have an increased risk of recurrence. This group tends to be RAS-like in terms of its genomic profile, compared to the BRAF-like infiltrative tumors, which present with a high TNM stage, have aggressive histopathology and have core disease-specific survival and recurrence-free survival when compared to the other subgroups. In terms of the limitations of our study, this is a retrospective study. This classification, the high-grade follicular cell-derived thyroid carcinomas did not exist when the majority of these patients were treated. So the treatment has evolved over time. 16 of the patients, we didn't have sufficient information on the slides to categorize them into subgroups. And for the genomic analysis, particularly the minimally invasive tumors, due to their rarity, we had a very small cohort of patients. And as discussed, we don't have data on the effect of radioactive iodine on outcome in the different subgroups, particularly the BRAF-like tumors, which would be very interesting to look at in the future. So I'd like to thank all my senior and co-authors shown here. Our paper has been recently published in Thyroid, and here is the QR code if you'd like to review that paper online. Some references, and thank you all for listening. I look forward to any questions and an engaging discussion. Thank you.
Thank you very much, Daniel. That was really a terrific presentation and a really outstanding body of work here. I'm going to call upon Dr. Robenshtok to give us some comments here. But I just want to go ahead, Eyal. I've got a whole list here, but go ahead and get started.
So first of all, this is a phenomenal study. Why? Because we have high-grade histology, but all these different types of encapsulated, non-encapsulated, invasive, non-invasive tumors, and we need to categorize them better for clinical management. And as Zubair said before, and he's probably going to discuss it, we have better understanding of the clinical presentation and the histology that fits together. We don't have really aggressive disease with classic PTC. We better understand why the disease behaves the way it is. Now, there are many open questions because it's relatively new classification. How to treat it? Should all of them have a completion thyroidectomy? Does radioiodine works? When does it work? So Daniel, you have a lot of work left for you. The worrisome thing I saw in the data, in the patients with encapsulated non-invasive disease, which apparently lobectomy is enough for, 2 had distant metastasis. And this is the biggest worry that we have when we do a lobectomy. When I do a lobectomy, I take into consideration patients can have thyroid bed recurrence, they can have lymph node recurrence. I never want to have them to have distant metastasis. So because they can get lost for follow-up and all bad things can happen. So I was wondering, and we can discuss it also with Mark and Zubair, maybe all of these patients need completion thyroidectomy, even if they don't get radioiodine, just for follow-up. So we're going to have thyroglobulin follow-up, and we can better detect these small number of patients. We still don't have guidelines. We still don't know exactly how to do it. But the difficult thing is when you have patients with apparently low-risk disease and high-grade histology. How should we treat these patients? Because when it's aggressive, we know how to treat aggressive disease. So I'll be happy to hear what you saw in the studies and what Zubair thinks about it.
Yeah, if I could just add one more part to that, because this really represents quite a paradigm shift for us to be looking at specific mutations that supersede histologic description as a driver of our surgical management. There's, aside from anaplastic, this would, for us to say that this subgroup with RAS mutations should be treated this way, really is a departure. And maybe, Daniel, if you want to comment on that and address Dr. Robenstock's comments, and maybe Zubair, if you want to get into the discussion here. Daniel?
Yes, it's certainly one of the most interesting observations to arise from this study is these patients with encapsulated non-invasive tumors with high-grade features who two of them down the line developed distant metastases, and they just had thyroid lobectomies alone. And then retrospectively looking at these patients, they had NRAS mutations. So is it feasible that all these patients in a rare subgroup, first of all, this needs to be identified in a rare subgroup histopathologically, and secondly, do we send genomic testing for these patients to identify the patients with RAS mutations? And perhaps that might not necessarily guide us to do a completion and radioactive iodine immediately. Maybe it will change the follow-up of these patients. Perhaps, as Dr. Robenshtok said, do we do a completion in order to then monitor the thyroglobulin in these patients? These are all questions that we have answers, but we don't clearly know the answers from this data because the study cohort is at this current time small, particularly for this subgroup.
Great, thank you. Maybe if I could quickly intervene with some questions from the audience before I hand this over to Dr. Baloch. The one question relates to the FAST protocol for ATC, which is something from that MD Anderson has. If patients are BRAF positive, they get neoadjuvant doublet therapy. Is there any role for this in infiltrative BRAF, the high-grade follicular cell-derived thyroid cancer? I tell you what, let me hold these for now. Zubair, we're going to come back to these questions. And Zubair, why don't you kind of jump into the fray?
So I think it's if we go to the basics, and let's not think about molecular pathology for a time being, because I think there's a good majority of the pathologists and clinicians are in countries where the molecular pathology is not rightly available, right?
Yes.
So if we really think about, and I think this is very interesting finding, that the ones which are low invasive or non-invasive group, where you had 2 patients develop metastases, right? And they were RAS like tumor and RAS associated tumors. I think what really is important that if a pathologist sees areas of necrosis in a tumor or high mitotic activity, and one has to be very careful also because most of these nodules get biopsied, and sometimes on pathology, it's very hard. I actually sometimes also find challenging, and I have to look away from the areas of FNA to really find true tumor necrosis. So when you find a tumor like this, you also have to make sure that you have adequately sampled or completely sampled the tumor and the capsular interface, because that's where the angio invasion happens, right? So if you have, this is a trigger, and I'm sure the way the Memorial Protocol is that all those 2 tumors were adequately sampled to really exclude angio invasion. So and also it also brings in a point based upon this data. I am still kind of little concerned about when we say focal versus extensive, right? So it's the breaking point is 4 or more vessels or less than 4 vessels. But we know that anatomically, the vessels within the tumor capsule, it's not like a sunny side up egg that has just 2 surfaces. It's a 3-dimensional structures, and the way the vessels travel in the capsule, you may be actually looking at the same vessel at a different points during sectioning, which is all just 2-dimensional. It's not a 3-dimensional structure. So when you really look at these things, those all stuff kind of plays in. So I think adequate sampling of a tumor that is showing high-grade feature, and I think which is actually, the mitosis. Also, sometimes it's very hard when you're looking at the slide. When you have an abnormal mitosis and you have too many of them, it's okay. But, counting mitosis can be really difficult. That's where some pathologists use Ki-67 proliferative index to really define how proliferative this tumor is, away from the areas of FNA. So all those parameters, if you take care of all these, and I think adequate sampling of the tumor, but you still see that there are these tumors. So for me, when I start seeing high-grade features, I have to make sure that I follow a protocol, adequately sampled, or sometimes I completely sample the entire tumor, and histology lab is not happy with it, to make sure that I do not miss. So for me, even a single focus of angioinvasion, I think it's a trigger to say this is an angioinvasive tumors. Yes, good number of this will not come back, but then you have a proof here that some of this come back. And I'm just going to say one more thing, that I just have a question for Dr. Scholfield. Was any of these were oncocytic tumors, or they were all basically follicular and papillary?
No, none of them were oncocytic.
Yeah, so which is good, because you are looking at the pure non-oncocytic follicular-derived tumors, because oncocytic tumors can be very different. So I think, and this is a very good study, but there's a study from MGH, and we also published something on these encapsulated tumors based mostly on the poorly differentiated carcinomas, because they both sit under the same category of high-grade non-anaplastic, that when you have an encapsulated tumor, a good majority of them do well. I cannot say but I think if it's a large tumor, let's say this tumor is 4 centimeters, encapsulated, you do not see angioinvasion, but you see high mitotic activity and necrosis. I think the discussion with the patient or the treatment should be different than something which is 2 centimeters or less and has the same type of features. And granted, there's nothing else in the thyroid that is an aggressive tumor. So I think this is where the personalized stuff comes in, which includes really a good understanding of the histologic features. And naturally, when you layer up molecular, it makes it much more robust. But you can see when you talk about NRAS-associated tumors, you go like, okay, it's NRAS, small, encapsulated, let's just do the lobectomy. But when the pathology comes back, you have to really rethink and have a different conversation with the patient.
Thank you so much, Zubair. Daniel, do you want to comment on that at this moment, or?
No, thank you very much. I think, yes, that is the most important thing, is the histological analysis of these tumors, to make sure there's no issues with sampling and correctly identifying and categorize them, which can be complex.
I would
Great.
like to add something, that it's important that we have correlation between the aggressiveness of the disease and the histological subtyping, but physicians will ask us, okay, things are getting complicated. How does it change the way I treat patients? So for now, I think we don't have enough information. Yes or no radioiodine? That's the big question. Because if you don't give radioiodine, you don't need to do a completion thyroidectomy. You can do a lobectomy in many cases. So I think we have a lot of work left, specifically whether lobectomy is sufficient, in what cases, who needs radioiodine, is it effective? So you did see in your study uptake in most patients in at least some of the distant metastases, but we know that if you see uptake, it doesn't mean it's going to respond. That should be the follow-up study, you don't have a control group, but just trying to understand when to give radioiodine and when not to.
But
Great.
Yes,
also interesting.
Hey, Zubair, can you just increase your volume? We're just having trouble hearing you.
Okay.
Not sure if you're able to do that.
Can you hear me now? Well,
That's awesome. Yes.
So it is also interesting that one of those cases, non-invasive or minimally invasive, whatever, they had the distant metastasis, that the metastatic deposit had actually acquired a different kind of profile because it had a TERT as well as MAP2K2. So I think, so that really comes to the point in the play that, either that metastatic deposit is happening in a small clone of tumor that basically was not, you're looking at, so I'm not a molecular pathologist, so I cannot comment on that, but I think to me, it's very interesting that there probably was a small aggressive clone of the tumor, which led to which caused, so that, because that profile is different than the primary tumor.
Yes, or whether that mutation developed further down the line, as we see with the progression of patients from well differentiated to poorly differentiated to anaplastic. They tend to acquire particularly TERT mutations.
Yeah, because that's very interesting, because we always knew there were these aggressive papillary carcinomas, no anaplastic component, and then you will see them in the lymph nodes or in the soft tissues, and they will have a small focus of anaplastic. So we have seen transformation, and we always thought of anaplastic and non-anaplastic, right? But now it's very important to start thinking on these lines, since we have these markers to do.
Yeah.
So let me jump in here, Zubair. The spectrum of thyroid malignancies continues to grow here. How confident can clinicians across the entire range of healthcare delivery feel confident that their pathologists are able to differentiate these various subtypes and drive clinical decision making? How nuanced do you feel this is here?
So, before this webinar started, I was talking to both Eyal and Daniel, and I said, we always knew, and I have gone back to the reports at UPenn like 25 years ago, and I saw late Dr. Lavolsi's report saying this tumor is a papillary carcinoma, but it has necrosis and mitosis, which should not be happening in your just a classic papillary carcinoma everyday case. So this one has some high-grade features. And if you look at the pathology literature, even long time before this WHO, from Dr. Tellini and others, there was always mention of these high-grade features in papillary carcinomas. Poorly differentiated carcinomas, because we had a bunch of experts sit together and come up with the criteria. And that tumor looks different because it has a different morphology. I think this category coming in, naturally when the new category comes in, everybody has to get used to this. But I think most pathologists and all pathologists who are even not head and neck experts can recognize necrosis, mitoses. There are strict criteria for diagnosing angioinvasion. So I think the confidence level should be very high, because we are not dealing with the small nuances where there's nuclear features of papillary cancer or not, there is minimal invasion or not. We are talking about tumors with necrosis and mitoses, and the ones which have angioinvasion. And most agree what a good angioinvasion is. So I think it's a pretty good, and I think the way the pathology is changing, we are looking more at not just these small nuances. Looking at follicular pattern tumors, encapsulated, infiltrative, papillary forming tumors, infiltrative, encapsulated, or oncocytic tumors. So I think it's all kind of coming to a point where the things which are important, the focus is more on that than saying, this is papillary cancer nuclei or not. So I think we are at a very good place, to be honest.
So Dr. Robenshtok, you brought the question up, and I'm going to bring it back to you now. Given what we know at this moment, and granted, some of these subcategories did not have robust number of patients, what do you recommend to a family member who diagnosed a patient? What are you going to tell them about undergoing a completion thyroidectomy if this is the diagnosis here?
So up to this study, I would say if there's no invasion, no capsular invasion, no vascular invasion, I would say that lobectomy is enough. I have to say that this study with the distant metastasis in 2 patients, it's not that rare because the group was not that large. I think it would be prudent for now to do completion thyroidectomy for these high risk, especially if they're larger, not 1 centimeter, larger tumor. I think it's going to be prudent to do completion thyroidectomy and look at the thyroglobulin, not necessarily give radioiodine, because if everything looks clean and thyroglobulin is 0, probably I wouldn't give radioiodine. But it's an unusual tumor. There's some risk of distant metastasis. I think that's for now, that's what I'm gonna recommend.
Dr. Baloch, you get a phone call from a patient who's just gotten this diagnosis. What are you going to advise them?
Well, luckily I don't treat patients, but I will say that, you know, your tumor is confined to the lobe, which is very important, to the thyroid gland. It's an encapsulated. It's not a tumor which is outside the thyroid or has vascular invasion. And I will talk to their clinician. And I mean, in the tumor board, I mentioned that what features are for or what features are against. And I think it's still the size of the tumor, because you can think about it in a kind of in a wholesome way, that, you know, when you're looking at the larger tumors and you're looking at capsule and you're looking for angioinvasion or invasive features, what we see is still representative, because nobody's going through the entire tissue block to exclude invasion, right? That's not possible in the practice. So, you know, what we have now, and I mean, radioactive iodine to me is a bigger bullet. So I will say definitely, if the thyroid is removed, you can actually watch and follow. And even the patients who do, even those patients, what Danielle showed, it still did well, correct, Danielle, as you're showing in the follow-up. So I mean, it's not the end of the world. You're not dealing with a metastatic lung cancer and stuff like this. And some of these tumors are going to do well. So that will be fine.
So Zubair, 2 centimeters with a RAS mutation, is that going to change your mind here, or what's going to drive your clinical recommendation?
You know what? And the bottom line is, molecular is good because it gives us insight. But if a 2 centimeter encapsulated tumor with a mitotic threshold of a high grade and a focal area of necrosis, I'm ready to take my chances and say that this patient is going to do very well. It just need a close follow-up and might not need total thyroidectomy, because you surgeons all know, even in the experienced hands, the chances of complication of our hypoparathyroidism is not 0, correct? And you're going in the neck. So, I mean, I'm not talking about you, Mark, but we all know the literature. So I mean, I will be cautious about saying, yeah, take your entire thyroid out and give radioactive iodine and stuff. So I will be, you know, that will be my conversation. I tend to be on more side that, you know, less is more.
Terrific. We are up against we've gone over the hour. I have a feeling we will be revisiting this particular diagnosis many times in the future here as more information arises. I want to thank everybody. Daniel, Zubair, Eyal, thank you for a really wonderful discussion this morning. Thank you all very much, and hope to see you all next week here. Take care.